Today we're talking about digestive health, more specifically a chronic condition that affects millions, inflammatory bowel disease, or IBD. Whether you're personally navigating the challenges of Crohn's disease or ulcerative colitis, or you know someone who is, this episode is for you. I'm joined by the medical director of the Inflammatory Bowel Disease Center at Hackensack University Medical Center, Dr. Alyssa Parian, who will be sharing her expertise on everything from diagnosis to the emotional impact of IBD. Dr. Parian, thank you so much for joining me.
Thanks so much for having me.
Of course. So I have to start off by asking you, how did you get involved in, what made you choose gastro?
Oh, that's a good question. I'll give you the short story of it. But it was one of those things where everything happens for a reason. I kind of got put into this rotation, and it ended up being kind of the best of both worlds. I really liked hands-on, procedural-based, but I loved following a patient longitudinally. My father was family practice, and I saw his practice and how he followed patients for decades, and I really enjoyed that. It gives me the opportunity to do something that follows patients for a long period of time and also do some procedures as well.
Got it. Okay. So jumping right in, what is IBD?
IBD stands for inflammatory bowel disease, which frequently gets confused with IBS, which is irritable bowel syndrome, which is very different. So IBD, or inflammatory bowel disease, really is made up of Crohn's disease and ulcerative colitis.
What is Crohn's disease and ulcerative colitis?
Those are two autoimmune conditions in which basically your body is attacking your GI tract and causing inflammation and ulcers throughout your GI tract.
Okay. And then are they a form of inflammatory bowel disease?
Exactly. Crohn's disease and ulcerative colitis are two of the most common forms of inflammatory bowel disease that we see.
Got it. Okay. So inflammatory bowel disease is like the overarching disease, and then these are smaller categories that...
Exactly. So if inflammatory bowel disease is at the top, then you kind of have the arrows down, and it's really ulcerative colitis or Crohn's disease.
Got it. Okay. So I think that I've heard of IBS more than IBD. I know that you said that they're very different, but what are the major differences between the two?
So the major differences is that inflammatory bowel disease, as I mentioned, is an autoimmune disease, and what it does is it creates a lot of inflammation, ulcers, bleeding, and pain throughout the GI tract. And when you actually do a colonoscopy or an endoscopy and you look in, you see these ulcers, and you could see this, whereas irritable bowel disease really has more to do with the nerves and the muscles of the GI tract, and when you do colonoscopy or endoscopy, they will look normal.
Oh, okay. So is that the way that you diagnose for IBD, is through colonoscopy?
That's one of the main ways that we diagnose Crohn's disease or ulcerative colitis is through colonoscopy. We also use blood work and markers in the blood, stool, especially to rule out any infections which could mimic or kind of look like ulcerative colitis or Crohn's disease. And then typically we use some type of imaging as well, like a CAT scan or an MRI. Most commonly, they're actually ulcers throughout the colon, and with Crohn's disease, also in the small bowel as well.
When you're looking at blood work then, what are things that stand out that you would kind of need to look more into to identify if it is IBD?
So blood work can give you a hint sometimes if somebody is anemic or a low blood count, meaning they've been losing some blood through the ulcers and inflammation in their intestines. Two would be there's inflammatory markers, abbreviated as ESR, CRP, and this are general markers that show if there's inflammation anywhere in the body, not specific to the GI tract.
Sorry, what is ESR and ERP?
So those are two inflammatory markers in the blood work. That's, when you draw blood, you could check them, and it looks for any inflammation in the body.
Once a patient is diagnosed with IBD, what are the next steps? And is it something that stays with them their whole lives? Is it curable? What are the treatments for it?
Yeah, so right now it's a chronic disease. So it's usually once people are diagnosed with it, they have it for their lifetime. There's varying severities of it. So some patients may have a mild disease their entire time. Some people may go up and down where they have bouts of flares and worsening of the disease and then remission. So, everyone experiences it a little bit differently. That's why if you read something online, it may not be what you're going to experience. Everyone experiences it a bit differently.
What could be other possibilities before you actually diagnose IBD? What else is comparable?
So what we rule out with stool testing is to look for any infections, because some infections can cause that inflammation and ulcers throughout your colon and intestines. So we'll look at the stool to make sure that there's no infections. And when we do the colonoscopy, we always take biopsies to look under the microscope. It's a little tissue sample to look under the microscope to make sure that it is consistent with inflammatory bowel disease and not anything else. The biggest one is infection, as I mentioned. There's also could be a very small risk that it could be a type of cancer, lymphoma that's there as well that we want to rule out.
Managing IBD, what are the treatments? What are the treatments for it?
We've actually exploded the number of treatments we have in the last few years, which has been amazing and makes me feel old to say back when I first started, we had one therapy, which was infliximab, or Remicade is the brand name as it's more commonly known as, and steroids, of course. And now we have a whole host of treatments, which is amazing and gives many more opportunities for the patients to have different therapies. And if they've don't respond to one therapy, there's other ones that they can try as well, which is different than how it used to be.
When you say therapies, is it medications?
Yes, sorry, medications.
That's okay.
Yes, so there's a number of different medications, many of them. So what happens with an autoimmune disease is your immune system is overreactive and it's attacking your body because it doesn't recognize it as itself, if that makes sense. Mm-hmm. And so most of our medications to treat Crohn's disease or ulcerative colitis are things to quell or calm down the immune system. So as you can imagine, they're not perfect, and so one of the side effects of them is a little bit of immunosuppression or lowering your immune system a little bit. But we're doing that to try and control it because it's a bit overactive.
Got it. Okay. Are there any things that aggravate your body when you have IBD? Like, are there things that kind of fire it up certain days?
Yeah, so there's different things that can flare it up or potentially worsen the inflammation. There's other things that could just maybe worsen your symptoms. So there's a number of things that we tell patients that they could do to help control it. So sleep has been shown to be a big factor, whereas your body recovers, your immune system heals. So we try and encourage patients to have as healthy sleep patterns as they can, try and get that 8 hours of restful sleep as much as possible. The other thing to get into, it could be a whole nother podcast, is diet and IBD. And we really, there's been many studies. Patients are very interested in what they can do with their diet. And what's been shown is really an anti-inflammatory diet, such as a Mediterranean diet, which is shown to be helpful in so many other things, and of limiting sugar, limiting red meat, limiting processed foods, fast foods, and really trying to have whole foods, whole vegetables, fruits, whole grains, lean meats, and have an overall healthy diet. That doesn't mean never have dessert. It's just, of course, limiting the sugar and intake, as that could flare up a little bit of the inflammation. And then exercise, of course, we'll throw that in there. That's always been shown to help as well with inflammation, and usually makes people just feel better in general mentally, but it also has been shown to really help decrease flare-ups and improve inflammation as well.
Does it matter what type of exercise? Like, is it recommended for like high intensity exercises, walking, weightlifting?
Yeah, anything 30 minutes a day for at least 4 days a week. So just something to get that heart rate up a little bit. So it could even be, a brisk walk.
Got it. Okay. So you said limiting a lot of foods. Is there any foods that need to be completely cut out of your diet or should be cut out?
No, I never like to go that extreme to patients because, there's a lot of foods that you have to enjoy too. Yeah. So I don't think anything totally has to be cut out. And I will caveat that by saying everybody's disease is a bit different. So I don't want to say that there's one diet fits all. There are some people who can get narrowing in their intestines, and those patients would be on a more specialized diet where we're actually excluding some of that roughage. Back in the day, we used to think that everybody with Crohn's disease or ulcerative colitis should have this kind of no-fiber diet. And that's what many patients were on. And sometimes they still come to me and they're not eating any of these really healthy things. And now that thinking has changed, and we actually want you to be eating all of those really healthy fruits, vegetables, with that one exception that if you do have narrowings, in your intestines, that might be something that's hard to pass through there. So you always caveat it by saying, check with your doctor for your specific disease.
Got it. So does diet have anything to do with developing IBD? Is it genetic? Like, when do you start showing symptoms, and how does your life habits impact that?
That's a great question. Really probably the million-dollar question of what causes IBD.
Yes.
We don't exactly know, but we do know that it's an overlap of genetics, your environment, and your microbiome, or the bacteria and microorganisms that live inside of you, because it's not just bacteria, there's yeast and there's viruses and there's healthy things that live inside of us that are really important to be there. And so it's that interplay between all three of them. So there's definitely a genetic component. It definitely runs in families, but even identical twins who have the exact same genetics do not both get it. If one of them gets it, the other one does not necessarily. They, of course, have a much higher risk, but we know, therefore, that there's something in the environment that then triggers it off.
Interesting.
There's some thoughts and some data about infections, antibiotics, smoking. Not one clear has come through, but there's some associations with these. And it typically manifests between ages 15 to 30 as the first kind of peak of diagnoses at that age. And then there's actually a second peak later on between ages 50 and 70 where you could be diagnosed and start noticing symptoms then.
So when you are diagnosed, I guess you do have these diet changes that you should keep in mind, medication, but how else does it affect your life? Like, what is it like living with IBD?
So what I usually tell my patients when they come in is that the goal is for you not to know that you have it, to get you in that remission, that you should be able to live a normal life, do all of your normal things. When patients present with this, what symptoms do they usually present with can be really varied. And that's why patients say, well, I didn't think I had it because I didn't have bleeding or I didn't have pain, but everyone can be different. So and that's where sometimes they'll split apart, whereas ulcerative colitis will have a bit more blood in the stool and diarrhea, going more frequently, having that urgency to kind of have to run to the bathroom. Mm-hmm. Whereas Crohn's may have a little bit more pain as a symptom before you're diagnosed. But it can also have bleeding, diarrhea as well. So you don't have to have all of the symptoms, and again, everyone experiences it a little bit differently. But then the goal with our medications is to heal up that inflammation, heal up the ulcers. So when we do look back in with a colonoscopy, it looks normal. It looks like you don't have it. And then you should feel like you don't have it. You should be able to get back to that normal life that you were living.
So with Crohn's, you said that there's pain. Is it like stomach pain or?
Yeah, it's usually in the abdomen somewhere because, that's where the inflammation is. And so typically patients will have it after they eat. They may feel a lot of bloating, some pain, some discomfort, and some increased bowel movements or looser bowel movements. Yeah, and it could be anywhere. The most common place for Crohn's is kind of on the right lower side of your abdomen, but not necessarily. Again, it kind of could be anywhere, which makes it a little bit trickier.
Yeah, no, that definitely sounds tricky, and figuring out whether it's Crohn's or whether it is ulcerative colitis. And the difference between treating ulcerative colitis and Crohn's, what is the major difference there?
So the major difference really is when it comes down to the surgical options. Many of our medications are actually approved to treat both of them. Not all of them, but 90% of them are used to treat both of them. So ulcerative colitis is limited just to the colon, and it's just that inside lining of the colon that's affected.
Okay.
It starts in the rectum and it ascends up. So some people, just the rectum's involved, sometimes just their left colon, and then other people, their entire colon could be involved for ulcerative colitis. Whereas Crohn's disease could be anywhere from the top, we say from the mouth, all the way down to the bottom.
Oh, really?
Could be involved. And not necessarily that it's all involved, but any part can be involved. And it's not usually this continuous pattern where they'll have some ulcers here, some ulcers there. And instead of just affecting the innermost lining, it affects the whole thickness of the bowel wall. And that's why they could get some narrowings or strictures in the bowels. And they could have, they're more likely to have resections, surgeries because of things like that.
So would you say that Crohn's is more serious of the two, or just different in treatment?
Just different. And I think the main thing with both of them is to diagnose it early and to get on the best treatment, because what we could show is that as soon as we get them on treatment and heal all that up, it prevents all of those complications from developing down the road.
Got it. So I did hear you mention a surgical procedure. Is that a treatment option as well? When is that brought into the picture, I guess?
So yes, we usually try and use our medical therapies, which have been very good at controlling inflammation. But like I said, in Crohn's disease, sometimes if the inflammation has been going on for a long time, maybe they didn't have symptoms, maybe they didn't realize, and our body heals inflammation by putting down scar tissue. And so with Crohn's disease, what can happen, and the most common place for Crohn's disease is right where your small and large intestines meet, and that's on your right lower side. We're talking where you might have the pain. And that's the most common area where it can become narrowed. And so things can no longer pass through there. So if that's just inflammation causing swelling, we could treat that with our medications. But once that's all scar tissue and kind of fibrosed, if you can imagine, there's no medication currently to reverse that. So sometimes they'll have to go in and the surgeons will open that up and cut out that small piece of intestines that's narrowed and then put back the other two sides.
Oh, wow. Okay. So when do you normally turn to do this? Like, is that a common surgical procedure that is used?
Yeah, for Crohn's disease, it's not uncommon, let's say. I think throughout the course of somebody's Crohn's disease, at least 50% of patients with Crohn's disease will have to undergo one surgery. So it's not uncommon to do that. And usually we'll turn to it once our medications have failed or if they start to have blockages in the intestines because of this.
So you may have to do this multiple times, though.
There are patients who need more than one surgery.
Wow, okay.
If this happens again, yes.
Okay.
That's why after the first surgery, we try and get them right back on treatment to prevent any more inflammation.
Got it.
And to prevent it from happening again.
Okay, so there is no surgery that is kind of one and done to help cure it, I guess, for lack of a better word, moving forward.
For Crohn's disease, no. For ulcerative colitis, as I mentioned, it's just in the colon. So you can do a total colectomy, meaning removing the entire colon and rectum. And that is a cure, as they say, for ulcerative colitis. And then that could leave you one of two ways. You can have an ostomy or a bag that collects stool, and your small intestines connects right to that. And, you don't have any colon. And people live very happily with that without their colon, without any issues. Another option is that they can actually, with your small intestines, make a pouch or almost a fake rectum, and they could connect you back together so you're actually not using an ostomy bag for it, but you're actually going normally, but without a colon, meaning therefore you'd have about 7 to 8 bowel movements a day. So you'd be going much more frequently, but you would be going without a bag too. So there are two options. So with ulcerative colitis, they do say that there is a surgical cure, which is a colectomy, but that does kind of
But it's a
alter.
tough decision to make. Yeah.
Absolutely.
Yeah. To almost have it as a little assistance, but it is taking away from what is normal to them now.
Yes. But sometimes the ulcerative colitis has been so severe, they're suffering so much, they're going to the bathroom 20 times a day, losing so much blood that it's a huge relief for them to not have to do that.
Yeah, absolutely. So how often should people be screening with a colonoscopy?
For a totally healthy person, it's every 10 years. If
Oh,
everything
wow.
is
I
good.
totally didn't know that.
So you're off the hook for a good 10 years if you have no family history and everything looks normal, you have no polyps. With IBD, it's usually anywhere from 1 to 5 years, depending on your family history, other risk factors you may have, how much inflammation you have and where. And so we always tell patients, don't forget about us when you're feeling well. That's the most important time that we want to make sure everything's going well inside of you. Polyps don't cause any symptoms for the most part until they become really big.
What are polyps?
Polyps are abnormal growths in the colon. They're abnormal cells that can then develop into colon cancer. The tissue, the lining of your intestines, and that kind of overgrows and it's abnormal cells, and then that grows bigger into a tumor and a colon cancer.
Oh, wow.
They are slower growing than other cancers, which is good. It gives us time to look and find them and remove them. And so that's why we do colonoscopy. So we remove these abnormal cells or these polyps when they're small so they can't grow bigger into any cancer.
How are polyps removed?
So they're removed during your normal colonoscopy.
Okay.
So we go in there and we, through the camera, through the scope that we use, we can put little forceps through. We could put something called a snare for a little bit larger polyp where we could kind of take out the whole thing once it gets a little bit bigger. And we suck it right out and it goes right to pathology so they could take a look at it under the microscope, make sure what type of polyp it is, and make sure we got the entire thing out.
Is it painful when you're getting a polyp removed?
No, actually the innermost lining of your colon has no pain fiber. So some of my patients do this awake. and they watch on the screen. It can be uncomfortable. It shouldn't be painful, but we do put air in you. So, you may feel that bloating, cramping, discomfort.
Yeah.
Most patients, don't get me wrong, 99.9% choose anesthesia.
I was going to say, I don't think I would want to be awake for that.
But some patients, especially doctors who are known to be the worst patients, like to stay awake and watch.
Yeah.
And if we take polyps out, they don't feel anything at all because there's no sensory fibers. Where you feel pain and discomfort is in the outermost lining. So that's when you get distension, or if you're having cramping and spasms of it. But if we're just removing or taking little tissue samples, you don't feel it at all.
Got it. Okay. And polyps are related to those with IBD? Is it that like a symptom of IBD?
Polyps are just more common in patients who have IBD. The general population get them as well. About 25% of people get them in the general population. But with IBD, that risk is higher because of the inflammation that they have there.
Okay. So after you do diagnose a patient with IBD, what does the next steps of getting onto the medication, once a patient starts feeling better, are they cured? Is that something that they have to keep checking up with you on? Do you have regular appointments with these patients still?
Yeah, for the most part, I see patients every 3 to 6 months, depending on how they're doing, sometimes more frequently if they need to come in more frequently. But it is a chronic illness, and we try and keep people on their medications. It's almost like high blood pressure, whereas it's normal when you're on your medication, but it's going to go back up or it's going to flare up once you stop the medication. That's not to say we can never stop medication at all. I never tell patients this is forever, but it is a chronic disease, and when you're feeling better, you shouldn't just stop on your own. I would have that conversation with your doctor if you have any concerns about your medication or you'd like to stop it. A lot of female patients have concerns about getting pregnant because patients are diagnosed during their childbearing years. And most of our medications are very safe during pregnancy. So I'd encourage anyone not to just stop their medications when they're feeling well, but to come and have an open conversation about any concerns you have.
Is that common for patients weaning themselves off of the medication?
Yes. I mean, some patients say, oh, my colonoscopy looked good, I felt good, so I thought I could stop. And maybe sometimes we're not as good saying, well, it all looks good because you're on a really good medication that's helping you right now. So, I'd encourage everyone to stay on their medications that they're on and talk if it's safe to come off and how the best way to come off of that medication would be. And to still come in, we still monitor the blood work. Even if they are off the medications feeling well, we try and pick up a flare or a mini flare or any inflammation before it starts, before it becomes a very symptomatic problem thing. Through blood work and stool testing, we can look for early signs of inflammation.
I think that is a case for most medications. I would think that you shouldn't just stop a medication just because you're feeling better. That, in my mind, would mean that the medication is working, and I guess you would want to stay on it to continue feeling good. So definitely talk to your providers if you're looking to get off of any sort of medication, and don't just take that decision upon yourself.
Yes.
I think that this conversation was very enlightening. I personally did not know 2 things about IBD, so I definitely learned a lot. I hope that you enjoyed coming in today. I hope that our listeners learned a thing or two about IBD, and thank you.
Thank you very much for having me. It was a pleasure.